Hello, Adam Smith-Connor here from New Forest Physiotherapy Clinic, and in this video I'm going to be talking about the anatomy of anterior knee pain. Now, anterior knee pain is a problem that tends to affect women more than men. It affects runners, and it's something that can be very difficult to treat because it's often down to the anatomy of your body. So if we look at the knee, I have a plastic knee here. Anterior knee pain is usually behind the kneecap, which runs up and down in the groove of the femur. We see this groove here. The kneecap has like a male to female fit inside that groove, and it moves up and down inside of that groove. If it's running centrally within that groove, then you won't have any problems. But if it's being pulled, usually it's pulled laterally outside onto the outside border, then that can grind and cause you anterior knee pain. It's a bit like a bicycle chain that's not correctly aligned. It will start to crunch and grind. Well, the same will happen with the kneecap. And what will happen is you'll get inflammation on the underside of the patella here, where it's running up against the side of the femur, just here. Now, that can happen due to a number of factors, some that we can control with physiotherapy, and some which we can't control with physiotherapy and that require surgery. So if we look at the knee on my diagram here, an important angle is the Q angle. Now, the Q angle is the angle between the anterior superior iliac crest on the pelvis, the bony part of the pelvis, and coming down to the midpoint of the patella. So that would be a line drawn down here, and then another line drawn from the tibial tubercle up through the midpoint of the patella and upwards. Now, on average, typically in a man, it's 14 degrees, and in a woman, it's 17 degrees. Now, the reason a woman has a larger Q angle is because the female pelvis is wider in order to make the birth canal wider for the head of the baby to pass through the pelvis. That's just an anatomical adaptation. If the Q angle is too big and too large, then what happens is the pull of the patella, the pull on the patella by the quadriceps, the Q is the quadriceps angle, what it will do is it will pull the kneecap outwards laterally more than it should. So what happens is the patella here is pulled outwards laterally, move my hand, outwards, and then that puts pressure on the back of the patella and on the femur. So angle here and the angle here, normally 15 degrees. If it's more than that, then the patella is going to pull laterally this way. Now, we can't do anything in a physiotherapy realm if you have a particularly wide pelvis, or if you have your tibial tubercle is in a external position. That will increase the Q angle, and also the rotation of the femur can increase the Q angle. Now, those are bony structures, anatomical structures that physiotherapy can't change. Surgery can, but physio can't. But what we can do is counter the pull of the quadriceps, the soft tissue. So the other thing we have to factor in is your iliotibial band here on the outside. You can see that on the video. So that's also going to put a lateral force on the patella. And your vastus medialis oblique, that's this muscle here on the inside of the knee. And what that will do is that will pull the knee inside. Now, often with anterior knee pain, this muscle on the inside, VMO, becomes weakened. And if you're a runner and you run regularly and you don't stretch it, what will happen is your ITB on the outside will become tightened. So from a physio perspective, on things that I as a physiotherapist can deal with, I'm going to stretch out the iliotibial band, and I'm going to give you exercises to strengthen your VMO. Now, some people say that stretching the iliotibial band is ineffective. Now, the reason people say that is, cadavers where they've taken the ITB out of the body and they've hung weights of it to test its tensional strength. It's been found to be an incredibly strong structure. So the theory was, it's so strong, trying to stretch it is not going to make any difference. But it's not dead tissue in a cadaver, it's a living tissue. And if you stretch it, in my opinion, it does make a difference. And in my experience, it does help to stretch that out. And the analogy I give people is, think of a tree. A tree is very strong and powerful, but a tree growing in a high wind location, it will grow at a slanted position to sort of position itself with the wind. However, if you put a fully grown tree there, it's not going to be blown over. The wind's not strong enough to blow it over, but if it's there long enough and it's affected by the wind over time, it will grow in alignment with the wind. And I think the same thing can happen with the ITB. If you stretch it regularly, it's a living tissue, it's constantly growing and changing, so it will adapt to the pressures and stretches placed upon it. So that's the anatomy of anterior knee pain. If you've got any questions, please post them. And if you could like and subscribe to this, I would be very grateful. Thank you.